Good morning, everyone. I'm Rebecca Vickers, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the chat panel. The button to open the panel is usually located on the lower right side of your monitor. Please use the chat panel to send any questions you may have as you think of them, and the presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, options to try on screen right now, and these options are posted in the chat panel. If you continue to experience poor audio through your computer, try rejoining the webinar and use the I will call in telephone option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance or CEUs. The recording and materials used in today's presentation will be available on FADAA's website within 30 business days. FADAA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on FADAA's website. You will need to register or sign into your account to complete the evaluation. Information you provide FADAA as a part of registering remains confidential. Statements of credit will be posted 30 business days after the evaluation closes. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note the evaluation will close midnight, Friday, April 29th. Up to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, please be sure to include your Florida license numbers for reporting to CE Broker when you register with our site. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx monitors arrivals and departures of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial CE credit. Dr. Julie Radler-Dulfer has more than 25 years of experience in human services and organizational development. As leading expert in behavioral health, Julie has been involved in various national, state, and community-based projects, including training and implementation of wraparound, community building, strategic planning at the system level, assisting organizations and systems through the accreditation process, training, coaching, and providing technical assistance. She also has facilitated leadership development through the Learning to Lead Leadership Academy since 2004. And now I'd like to welcome Dr. Julie.
Good morning, everybody, and welcome. I'm looking at the list of participants, and it's nice to see some friendly names. I wish we could be together and we would be seeing friendly faces, but we'll do the best we can today. And welcome to Prevention Strategies to Address Behavioral Health Disparities. We're going to be together for the next 2 hours, and we will do some activities. Unfortunately, there's not breakout sessions in this workshop. However, you can, we'll just kind of like talk you through them, and you can participate by putting information into the chat. You won't be able to see each other's chats. However, I will be able to read some of the chats out loud to you, and Becca will be able to do the same. So that way we'll be able to kind of share information that you guys are sharing with us throughout the training. So without further ado, go ahead and So you've already met me, but here's a nice updated photo to get bottom the new updated photo. So my name is Julie Radlauer-Dorfler, and I'm the CEO of an organization called Collectively. As I've already been introduced, I have over 25 years of experience. The majority of my experience is in human services, working with nonprofit government organizations, quasi-government organizations, and then communities. And here's my contact information, should anybody want to contact me afterwards. Today, we are going to be talking about inequities and disparities. And so we're going to identify the barriers for behavioral health treatment for people from diverse race and cultural backgrounds. We're also going to be talking about and understanding the difference between equality and equity and understanding structural racism and disparities. We're going to just learn a little bit, tiny little bit about the historical perspective of structural racism, but we're also going to spend some time talking about cultural and environmental and structural components in current behavioral health services. We are going to talk a little bit about how to help professionals working in the field better engage the families that they're working with, and also talks about some evidence-informed approaches to work with people who represent different racial and ethnic backgrounds. So why are we here? Well, we're here because looking at the current behavioral health system, well, this is not even current. This is 2020, so this was right before COVID. But so now we can even just imagine that the capacity is actually less, because we know we're struggling with capacity in the behavioral health system. But just in general, when we're trying to help people who are struggling with mental health issues, 50% of white Americans who are struggling with mental health issues do not access behavioral health services. And we can understand those reasons to be insurance. Some of it is related to stigma. Also, it could just be lack of access in their area or their community, and other social determinants of health. When you look at the same information for Black and Brown Americans, it's almost 70% do not choose to access or have access to behavioral health services. And the research shows that only 1 out of 3 African Americans with behavioral health conditions will receive the services that they need. And so when we look at this, we say, well, okay, so our system just, again, this is pre-COVID, so we're definitely in a more difficult situation now. The majority of people who are experiencing mental health conditions don't look to the behavioral health treatment system to meet their needs. And so as behavioral health treatment providers, we have to look at ourselves and our systems and our organizations and say, well, why is that? What is it that we're not doing that would make people who are struggling with mental health conditions choose to access services, which is ultimately our goal, is to help people through whatever needs they have. So let's kind of start off with just understanding a little bit about the language, if you will. One of the things that I think people sometimes get confused around this work is the difference between equality and equity. And so equality means that everybody's really given access to the same resources and the same opportunities. And in a perfect world, we want that to be the case, that everybody has this, it's a level playing field and everybody has the same access. However, what we know is that in our current systems, equality doesn't exist because we really want equity. And equity means that your race, your identity, it doesn't determine how you fare in society. What ends up happening is that if we give everybody access to the same thing in the same way, we're not taking into consideration what are some of the other barriers that those people might have to receive services. So for example, if we say, okay, well, there's 10 spots available for psychiatric appointments, and whoever wants them, just call and make an appointment. Well, okay, so not everybody can call during the day. Some people who are at work don't have access to make that telephone call. So then it's not equal. So, and that's just a simple example. If we say, okay, people need to come in for appointments, and if you're 15 minutes late, then you no longer can have access to your appointment. Well, inequality, we say, well, everybody, it's the same thing. Everybody has to show up at the exact same time. Everybody has the same 15-minute grace period. Okay, but is it really the same thing? Because people who come from low socioeconomic communities may not have access to their own transportation, and they might have to take public transportation. And can they account for the fact that public transportation is going to get them there exactly at the same time? So is it equitable? And so we have to recognize that there are many barriers in our existing system, in our existing world, that don't make it a level playing field, and we have to figure out how to do that a little bit better. Another important definition for our work is structural racism, and this really refers to like the laws, the rules, the policies that continue to perpetuate these inequities. And we'll talk a little bit more about that. This training is not specifically around that, but we're going to talk about it a little bit. And then disparities. And what the research shows is that disparities really are created in many respects due to structural racism. So those policies and those rules and those laws that are in place result in people not having the same access. So a disparity is when one group is systematically faring worse than another, and it's not due to their needs or their preferences even. It's due to the lack of access that they have to have their needs met. I'm going to read you a quick excerpt. This is from the book Caste by Isabella Wilkerson. So, we in the developed world are like homeowners who inherited a house on a piece of land that is beautiful on the outside, but whose soil is unstable, loam, and rock, heaving and contracting over generations, cracks patched, but the deeper ruptures waved away for decades, centuries even. Many people may rightly say, I had nothing to do with how this all started. I have nothing to do with the sins of the past. My ancestors never attacked indigenous people. My ancestors never owned enslaved people. And yes, none of us were here when this house was built. Our immediate ancestors may have had nothing to do with it. But here we are, the current occupants of a property with stress cracks and bowed walls and fissures built into the foundation. We are the heirs to whatever is right or wrong with it. We did not erect the uneven pillars or joists, but they are ours to deal with now. And any future deterioration is, in fact, on our hands. Unaddressed, the ruptures and diagonal cracks will not fix themselves. The toxins will not go away, but rather will spread, leach, and mutate, and they already have. When people live in an old house, they come to adjust to the idiosyncrasies and outright dangers skulking in an old structure. They put buckets under wet ceiling, prop up groaning floors, learn to step over that rotting wood tread in the staircase. The awkward becomes acceptable, and the unacceptable becomes merely inconvenient. Live with it long enough, and the unthinkable becomes normal. Exposed over the generations, we learn to believe that the incomprehensible is the way that life is supposed to be. And I read that to you guys to just put a little bit of a framework around what it is that we're going to be talking about, these disparities. Our structures and our systems have been in place for hundreds of years. And because of these structures and policies and processes, we have these existing disparities or inequities, which is really what this training is all about. And we can't really change the disparities and inequities without looking at the structures and the systems that have created it. And while we were not the ones that created these systems, we are in a position now where we have to do something about it if we want to create a more equitable behavioral health system. So part of this is just around self-awareness and awareness of the system in which we work, so that we have a better understanding of how we need to show up differently for the people that we're working with in order to decrease these disparities or create more equity. So I'm not going to review this, but I just wanted to give you a little bit of perspective. This is part of some research that was conducted on structural racism in the behavioral health system. And I'm just going to give you one example of how this really plays out, but this is a whole kind of separate training. But it's important, I believe, for people that work within the behavioral health system to recognize and understand that the system was created And when you look at the system with this kind of cultural lens, you can see how the way that the system was created hundreds and hundreds of years ago creates some of the inequities that we see today, creates some of those disparities that we see today. And so we have to understand the historical perspective and recognize it so that we can, again, show up differently. So here's an example. On the slide that I just showed you, one of the things that was on that slide was in 1910, the Flexner Report. So the Flexner Report was a report that was commissioned by the federal government to look at universities, actually medical schools, and to make sure that all the medical schools that were currently open were, meeting the standards of medical schools. The report resulted in 5 out of 7 historically Black college and universities closing at that time. And so we say, well, maybe those facilities were substandard. Well, just the fact that there were universities for Black and Brown people is something that we should celebrate, right? However, because they didn't meet whatever standard, which was, centered on on that present day government standards, 5 out of 7 of them were closed. And so the result of that, when you look today, is that there would have been an additional 27,773 additional Black and Brown doctors that would have gone through those universities between 1910 and 2020. In the year 2019 alone, there would have been an additional 355 Black medical school graduates, which would be a 29% increase from where we are at that time. And why is this important, you ask? Well, when you interview Black and Brown people who are experiencing mental health conditions and want to receive treatment, 100% of them say that they would prefer to work with a Black or Brown professional. And so you can see that we're not able to meet the needs of Black and Brown people because of policies and processes that happened, over 100 years ago. And when we recognize that, we then have to figure out, okay, so if this is an important need for this population, how do we resolve this? What are we going to do about this? Right? Which that's kind of the inequities is perhaps many of the people who are Black and Brown who are experiencing mental health conditions really only want to work with somebody who looks like them. And unfortunately, there's not enough of them to go around. So then that's an inequity in our system that stops Black and Brown people from getting the help that they need. So we have to be able to look at all of these different policies and processes that we have in place that prevent people from getting the support that they need. We're going to watch a video now. So this video really kind of explains the difference between equality and equity in a way just so that you can wrap your head around how we might need to do things a little bit differently. So I hope that you liked that video. I think it's a really good representation of the difference between equality and equity. I think what's really important too is just to recognize that, this work is hard. It's difficult to kind of come out of your own space and see what others are experiencing. But I love that just the solution of just have conversations with people that are different than you. And just ask genuine questions and try to get to know them. We have the ability to do that in the behavioral health field, and we do that with the clients that we're working with in a probably more clinical setting or in a more clinical way. And really what we need to do is also, and we're going to talk about engagement later, do this in a more engaging way than perhaps we've done in the past. And so I hope that that was helpful for you. So let's talk a little bit about some of the examples of inequities or disparities that exist in the behavioral field. And we're not only going to be talking about based on race and color and ethnicity. You heard in the video, they're talking about, LGBT, talking about people with physical disabilities. So we have to really just recognize that, in behavioral health, we're going to be, some of the data that's being shared is based on race, ethnicity, but we have to be thinking more broadly than that, and specifically from a prevention perspective. Okay. So, but an example of an inequity, just to be concrete about it, is 31% of white children with mental health problems receive the mental health services, and 13% of children from diverse and ethnic backgrounds receive the same mental health treatment. So you can see right there that disparity, 31% white, 13% other. That is, what we're talking about when we say inequity or disparity. So let's get an understanding about why some of these inequities exist. Now, we can talk about some of the structural barriers, and we did just briefly talk about kind of the structural racism, if you will. Another really important component for people to understand is something called social determinants of health. Social determinants of health really comes from that kind of the public health arena. And it helps us to understand what they are so that we can see how they impact society. And so, for example, socioeconomic factors is one of the big social determinants of health. And that is really encompasses things like, your access to education. If you think about, in Florida, the schools are, the tax base for schools come from the community directly surrounding that school. And so you can imagine that schools in low socioeconomic areas have less access to resources than schools in wealthier areas, right? And that is a social determinant of health. Also, job status. If you go to school and you're not as educated because the school that you went to didn't give you access to all the resources, are you going to be able to get the same level or caliber of job of somebody else? Additionally, family support, social support. If your family is working multiple jobs just to pay bills, that's different than if you are growing up with a stay-at-home mom or a stay-at-home dad. And that, again, decreases or changes, your experience in this world, as does income, obviously, right? And then also community safety. If you live in a community where you really shouldn't be out after dark, that really changes your access to support systems. And going to the local park to participate in teams and that kind of thing. So you can see how those socioeconomic factors would impact people and ultimately their mental health, right? Additionally, there are physical factors, there are health behaviors, and there's access to healthcare, right? And so all of these social determinants of health directly result in what we would consider to be kind of those disparities or inequities. And so we have to recognize that, can we control these things as a behavioral health professional? Not necessarily. I can't control somebody's income. I can't control somebody's education. Could I have an impact on their health behaviors? I could. I could have an impact on their access to healthcare. I could. Now, completely no, because there are some cultural beliefs too that also play a part in this. Or if you think about health behaviors, like, for example, diet and exercise. Well, if I live in a low socioeconomic community, many of those communities do not have access to, say, like a supermarket or healthy foods. And the majority of people purchase their food at, say, a corner store where there's more processed foods, which then impact your body. And so it's really complicated, and it actually gets us to this point where we're like, oh gosh, well, I don't feel like I can make any difference in this world because these seem like too big of issues. And so my take on this is that these are really big issues, but we in the behavioral health field, if we just focus on our system and make an impact within that system, we can help society. We can make an impact. Are we going to change the housing system? No, right? Because we're in behavioral health. However, there are people just like us who work in the housing arena, and perhaps they could focus their efforts and their energy into the housing system and try to create some more equity in that system. So it becomes really our responsibility to, pay attention to what it is that we can control, our controllables, if you will, and how we can make a difference in our space, in our behavioral health space. So let's talk a little bit about some of the community conditions that create these inequities. So, for example, we were talking about in low socioeconomic communities, the people that live in low socioeconomic communities are exposed to more ACEs, adverse childhood experiences. And because there is more violence, more gun violence, and so that alone, children may not have access to as parental support if parents are working multiple jobs, which leaves children somewhat vulnerable sometimes. So that's something that we know creates these and continues to create these inequities. Also, in lack of insurance or underinsurance. So 30% of the uninsured are Hispanic and 13% are Black, 13% are white as well. So you can see that that's something that would stop people from going to seek support if it's going to cost them a lot of money. The need for culturally competent providers, and I shared that example with you in the Flexner report. In addition to people getting trained so that they can address. So you guys coming here today, you're trying to create equity, which is a beautiful thing. So thank you for being here. We talked about, the lack of access to providers. 2% of mental health providers are Black and brown. And so if you just look at the number of Black and brown people in our communities, it's more than 2%. And so people who are experiencing mental health don't have access to providers that look like them. The historical distrust of the health system in general, not specifically the behavioral health system, though there is mistrust of the behavioral health system as well. And so things like, Tuskegee give us examples of why there is kind of this like historical mistrust of the system, because a lot of, throughout history, this kind of mistrust has led, mistreatment has led to mistrust. And then stigma. And so, for example, in the African American community, 63% of African Americans believe that expressing a mental health condition is a personal sign of weakness. And so if culturally I'm not comfortable talking about it, I'm not going to talk to my friends or my family or my faith providers, and I'm probably not comfortable talking to a majority white professional either, and I might not have insurance, or if I do have insurance, there might be a copay, and perhaps the system is confusing, and so we have to just wonder, like, how do we fix that, right? There's so many things that we have a lot of work to do in our system, just in our behavioral health system. So just to give you some frame of reference, and this data is more specific to the African American population because of some research that I was doing. But so the African American are overrepresented in our prisons. At 60% of the prison population and 30% of the drug arrests, but only 14% of the drug users. See the inequity there, the disparity there. In 2017, suicide was the second leading cause of death for African American youth. That continues today. That number has actually gone up. The rate of mental illness in African Americans is the same as the general population. However, the disparities exist in the quality of care, access to care, and access to culturally competent care, which we've already spoken to. And then to look at the African American, the makeup in the population is 13%, but they're overrepresented in high-risk populations. Like, for example, 40% of the homeless population are African American, 60% of the prison population are, and 45% in the child welfare population are. So, we have to recognize that there are these inequities, and it's across every system. It's not just behavioral health. So this is an infographic that I use in a training that I do, and I just kind of wanted to share it with you. It will be on my website, and you have my website information. It'll be on my website later on this week. So looking at some of the structural issues that we already talked about, such as, poverty, such as the organizational policies, like things like mandatory reporting policies, having lack of access to transportation, not having a good, the power structure of the clinical relationship and how that relates to people wanting to receive services, right? So these are some examples of structural issues in the behavioral health system. And then what happens is, because of these structural issues, we have these inequities, like 63% of African Americans believe that expressing mental health is a sign of weakness, or the mistreatment that has led to mistrust, or that suicide rates in Black African American girls has gone up 182% in over the last 20 years. And so we have to look at this and say, well, what do we need to solve? How do we stop the suicide rates from continuing to go up? How do we decrease the number of Black people in the high-risk populations, like homelessness and in our jail systems? So we also, though, have to look at how we as professionals in the system, how our bias shows up and influences things. So if you've ever said, I went to school for this, so I'm considered an expert. If the family didn't need my help, they wouldn't be seeking services. That's kind of our bias showing up, that we are more than the people that we're working with or trying to support. I feel that I'm working harder than the client. I can't imagine, and I hear this all the time from people who are frustrated that the families that they're working with are not participating in services, but we can't really imagine that we're working harder than somebody who's experiencing their own mental health conditions, right? But those words come out of our mouth. That's our bias showing up. I understand that the family, doesn't have transportation, but how can we run a business if they don't show up for their appointments? That's not recognizing that, maybe they have to take multiple appointments to get, or multiple modes of transportation to get to an appointment, and they might not make it there within the 15-minute window. And then, the family's not coming to their appointments, they must not care about their situation, or they must not care about their children or their family. And obviously that's not true, but that's how our bias shows up. And what we need to do about this is think about, well, how do we show up differently? How do we, as behavioral health professionals, what do we need to do so that we can better engage and better support the people who, are within our systems? I encourage you guys to add information into the chat. Like, how did this slide right here, what are some thoughts that come to you when you think about this, or when you hear this language? Okay, excellent point. I want you to think about this, because we're going to talk a little bit about bias moving forward. So understanding our bias and our unconscious bias, it's important for us to recognize that, and you probably have all seen this at some point. You see the iceberg and floating on the water, and you look and say, okay, well, this is what's on top of the iceberg, but from what we know about icebergs, there's so much more underneath. And so what's easy to see when it comes to culture is, our language, the way we celebrate our holidays, the foods we eat. But then what's difficult to see are some of those beliefs and assumptions, our core values, those biases that I was just speaking to, our body language, So when we're trying to connect with people, we have to recognize that our bias plays a part, as does other people's bias play a part. So what is this implicit bias? Um, Implicit bias are the products of just learned associations through social conditioning. I think at some point we kind of say like, oh no, I don't really have bias because we feel that we shouldn't have a bias. But the truth of the matter is everybody has bias. It's just the way we were brought up. And so I'm going to show you a couple of examples so you can see that it doesn't have to be something so serious as like, oh, I don't see people of a certain color or race or people with a certain disability the same way. We all see things the way that we just were exposed to them. And so it's possible to unconsciously associate positive and or negative traits to what we've learned, to who we are, to being a woman or being of a certain race, or even, our background, because of the way that we've just been brought up. So a couple of examples are just to recognize that our bias, they are totally like automatic, unconscious. Most of the time, we're not even aware of them. And it's a good thing to kind of learn about your bias. And you can go to, if you just Google Harvard Harvard implicit bias, you can take some implicit bias tests. And the tests that they have there, I mean, some of them are about race and ethnicity, but some of them are about like, do I like my thoughts about, guns, or what are my bias about, I think there's political ones. There's bias about foods. There's bias about weight. It's not specifically to race, ethnicity. But for example, how do you refer to these things? Soda or pop? That's from where you grew up is how you refer that. Ice cream or custard, diabetes or sugar, urban or city or neighborhood or hood. So we just kind of need to be like aware of those. And the more that I'll put the website in you're going to watch a video in a minute. And so during the video, I'll put the website into the chat for you. But it's the Harvard implicit bias test. So the more we're aware of those bias, it helps us kind of show up differently for people with people. So it's important to understand your bias and check it. So you'll find yourself saying like, oh, I wonder why why that person did that. Just the fact that I recognize that and said, why did that person do that? That's my bias showing up. Right. And, like me and my friends, we talk about it so much that now it's kind of like, a nice bias showing there. We kind of even joke about it because the more we talk about it, the more we're aware of it, the more we can make changes to it, should we choose to do that. So we are going to watch a video. This is an example of, in the behavioral health arena, how our bias might show up. And there's some reflection questions. So after you watch the video, I'm going to put the reflection questions up. And I would love to encourage you to put information into the chat. Okay, so I know that video is disturbing, is the word that I would use. But so I want to invite you to just take a moment. You can either just write these down on a piece of paper, or if you're comfortable, put it into the chat. But um, just for a moment, let's reflect on what we just saw and where do we see ourselves in this video at all? Reading the chart before the client comes in and already having our preconceived ideas about, you know, that it's their fault for, the way that they're acting. Um, do you see yourself, like what was so difficult? What was the most difficult part of that for you? If you want to put that into the chat. Um, how would you hope that things would be different? I think is something that, if we're going to try to like recreate or redesign this, that would be something. So some people are putting into the chat that I don't read notes before, specifically for that reason, which is great. Um, People are saying that when this looks like them when they were young and just coming out of school. Um, and so that's something that if you think about within the systems which we work, the salaries that many behavioral health professionals make lends itself to people who are young and inexperienced. And so that also then perpetuates people who are really struggling having access to people who don't have a lot of experience. Because I myself probably made the same mistakes when I was, in the good old days when I was young and inexperienced. So, we have to think about how does that continue to perpetuate these inequities, the way that our system's designed and the, case loads and salaries and expectations. So I think, again, this is an opportunity for us to look at our system and look at the way that our system is designed and try to figure out how are we going to show up differently for the people that we're working with. I just did an implicit bias training with an organization up north, and um, that just from sitting through the training, one of the people came back and she said, "You know what? I've been working with this family for a couple of months, trying to get them to be engaged in services." And she says, "I was just about to do the 3 no-shows, and I'm closing your case letter." And just from sitting in the training, she said, "I decided to just get in the car and drive over to their house." And she said, "And we just had the most amazing conversation, and we're going to try one more time." And I think that that's kind of what we have to do, is just recenter and like, well, why are we doing this? And what do we have to do differently? If it's really about the people that we're working with, and the clients and the children and the families that are struggling, then shouldn't we go out of our comfort zone to support them more? And it just, you know, somebody wrote in there, is it ever okay to correct one's grammar during therapy? No, it's not. But though, do we do that? If somebody is mispronouncing something or mispronouncing it based on our standards, are we thinking, maybe we don't say it out loud, but are we thinking that? Maybe that's something in itself, is just to recognize our bias around that. That we want people to speak more, Eurocentric English. So thank you guys for sharing information. Um, I appreciate some of the conversation, even though it is sadly typed in, and we can't be, having the conversation together. But I encourage you to continue to reflect. Maybe write down some of these questions before I switch the slide, or take a picture of this, and reflect a little bit on, this video afterwards. I want to share with you just a snippet of some research that was conducted as part of my doctoral project, which was looking at the structural racism in the behavioral health delivery system. And I just really want to share with you an overview of what the result of that research says in terms of what we could do differently in our systems. So basically, these are the final results from I interviewed African American families of children with mental health conditions from across the United States. They said that professionals in the field need to be educated about different cultural, racial backgrounds, ethnicity, how to deal with different people of different populations. So here we are. Yay. Also, they said that because of their cultural beliefs, they're not necessarily looking to go into formal treatment services, if you will, but they would prefer to get their mental health needs met through social support, like family, faith, and friends. And so we're going to talk a little bit about that before we finish today. Also, they said that just the way the system is designed, it meets the needs of like the funder, the insurance company, more than it does the people in services. And so, for example, caseload size or using evidence-based practices that were researched mostly on white people may not have the same efficacy on people of color. Or salary, like I mentioned, the salaries in our industry are so low that younger people who are just out of school tend to be working in community mental health, which then people who are really struggling with big issues like social determinants of health issues are having somebody who's just fresh out of school, a novice in this field. Remembering that people that are exposed, that live in low socioeconomic communities also have more exposure to ACEs, which is really complicated work and trauma-informed work. And so inexperienced people are providing deep end services to people who are really struggling. And that's a problem because we don't get the best outcomes necessarily. Also, people believe that that we need to do a better job of addressing stigma in the community, which is more community education and outreach, if you will, which, so that community engagement piece. Voice and choice is a huge thing that came up over and over and over again in the research, is that people wanted to co-create the system to make it into something that would really benefit them, as opposed to a bunch of professionals sitting around saying, okay, well, we need to change this policy, is to include the voice of the people who would be receiving services at the table, so that whatever is created is something that will actually benefit all of us, not just some people, will benefit everybody. And then that need for more Black professionals so that people can receive services from people who look like them, which is a larger system issue, but nonetheless, something that came up in every single interview, that people said that that's what they wanted. So I wanted to share this research with you. So this is the voice of families saying this is how they want to have their mental health needs met in a different way than we're currently doing that. So let's talk a little bit about, actually, you know what? Before we move on to engagement, I think this is a perfect time to just take a quick break. It is 10:54. Let's come back at 11 o'clock. Since we'll be together till 12, I want to just give you 5 minutes to get up, stretch, and when we come back, we'll start talking about engagement.
Hello, everyone, and welcome back to today's webinar. I will pass it back over to Dr. Julie. One moment.
All right, thank you. I just wanted to take a moment and respond or talk about some of the things that were in the chat bit from the video. Like somebody commented about the fact that the doctor was going to report the situation to child protection. And I think that that's something that we have to consider when we talk about things like mandatory reporting, in which we're going to talk a little bit about boundaries and some of the structural barriers that create, this lack of engagement in our system. And so that's a good example of that. And that happened to me too when one of my sons was really young. He was so clumsy and he was just covered in bruises all the time. And one time the doctor kind of like got in between the two of us and was asking my son like where he got each of his bruises. And I'm thinking to myself, oh my goodness, he's going to call Child Protective investigations on me because my child is so clumsy. But yeah, I actually appreciated it because I thought, well, that's a good doctor who's, trying to look out for my child. Though, yes, it was a little offensive at the time, granted. So let's talk a little bit about engagement. We know that engagement is important. When you think about that video and you think about how that whole video even started, where the first thing she did was kind of like throw his file at him. Is that good engagement? Is that what we want engagement to be like, to look like, right? So having said that, there's bias on both sides, which makes it difficult for engagement to occur. People come into treatment service, especially if they're court ordered, with their own bias around the professional that's going to be working with them. And then those in the helping field, we have bias about the people that we're working with, whether it's about their age or how many children they have, or if they show up late or miss an appointment. All of that is bias that shows up, right? But what we know about engagement is that uptake in services is directly related to engagement. And by uptake in services, we mean people connecting and engaging in services. So, 60% of children in the mental health system do not receive the services that they need, period, right? And that both adults and children, a dropout occurs usually after the second or the third session, which clearly speaks to a lack of engagement if it happens that early on, right? And then for both adults and children, the dropout rates for mental health services range anywhere from 35 to 70%. So that's not so good. 35 to 70% of people that go to services drop out of services. That is an indication that we should be doing something different or better. When you're working in homes, which, some people are, some people aren't given COVID, but if somebody offers you something to eat or drink, would you accept it? If you don't accept it, how does that, work as towards engagement with the family? Just think about it for a second. When working, have you ever shared information about your own personal life? So, those in the helping field have been taught that they should not share personal information. And though, if you think about making a connection with somebody, if the client that you're working with or family that you're working with wants to get to know you a little bit before, or like ask your opinion about how you address certain things, and your response is, I can't share that information with you, or something to that effect, well, that doesn't really lend itself to engagement, right? So thinking about some of these questions, you have to kind of ask yourself, how do you handle situations like this? How about giving a hug? If somebody wants to give you a hug, either a welcome hug. So is that cultural? Do certain populations of people hug more than others? Some might say yes. And so if you're not willing to hug, but the people that you're working with, that's how part of like their culture and how they express themselves, what are you doing for engagement there? How about something as simple as taking off your shoes? Some professionals or people that work in the field will say that absolutely not. I would not take my shoes off in somebody's home. And then there are probably many people on the call who, when somebody walks into their own home, you expect them to take your shoes off. So if somebody refuses to do so, what does that do to engagement? Do you want that person back in your home because they didn't really follow the rules of your household? Talking about how you share your holidays. We have this idea that if we tell people, oh, well, I'm a certain religion and I share and I spend my holidays this way, well, is that too much personal information or is it not? So I think these are all important things that we need to really think about, when we're trying to address engagement, which is something that's really important. So some people say, well, I don't accept food or drinks, period. I don't. And I will blame it on my organization and say, well, it's an organizational policy. Well, it's not an organizational policy. It's an organizational policy usually that you can't accept gifts. It's not an organizational policy that you can't accept, a bottle of water or a glass of water. Now, if you're not comfortable, then you can bring your own so that you can say, oh, well, I have my own water bottle. Thank you very much. The thing about hugs, that's something that people, different people view that in different ways. And it sometimes is awkward. So you have to and again, there's not a right or wrong for most of these. The purpose is we're trying to figure out how do we best engage with people. And so if you think that any of these things could potentially interfere with your ability to connect or engage with somebody, well, then you probably should kind of rethink how you want to do that moving forward. So again, if anybody has any questions, I encourage you to put it into the chat. But these are things that you should be paying attention to say, like, do I do these? Do I not do these? What do I say? If my answer is no, what do I say? So as to continue to have good engagement with people. Because that's really the goal. So let's talk about some common barriers to engagement. Well, so social determinants of health are a common barrier. If I am dealing with poverty, or I'm not able to meet the needs of my family, or I'm worried about food and shelter, I'm really not concerned with making it to a therapy appointment, right? That whole Maslow's hierarchy thing is real. And so, that's a barrier for sure. So that transportation, childcare, loss of employment, if I have to take off to go to appointments, then I can't take off. And that also becomes a barrier. So, we might think, oh, this person is not invested in the treatment. Well, no, it's because they can't take off at 3:00 in the afternoon. And, we're not working at 8:00 at night when they're finished with work, or, they're tired at 8:00 at night because they've been working all day. So dealing with their mental health is not necessarily their priority. Also, common barriers is stigma and people's attitudes about just mental health in general. In many, and we're going to talk about this in many cultures, you don't talk about mental health, and if you do, then people look down on you. So that's a problem. If I'm experiencing mental health, but I don't feel comfortable talking about it with my people, how am I going to, address it? And then if I say, well, I'm going to go talk to a therapist, then everybody knows I'm experiencing mental health issues. So then I'm hiding that. And I don't feel comfortable even sharing that I'm going to see a professional. That's a problem, right? And so we have to, as a society, kind of work through this. I think that has gotten just a little bit better in COVID because, I don't think you can throw a stone and not touch somebody who's struggling with mental health, issues at some level. And so talking about it has become a little bit, better. It's more acceptable to talk about it. Previous negative experiences with providers. If you think about that doctor from the video, or you think about that therapist from the video, if you were either of those people, would you want to go back to those providers? No. And next time you have to go to a doctor, are you going to think twice about it? Probably, right? And so those negative experiences with people impact future uptake of services. Fear of mental health system surveillance. And that's just a common thing for all systems, not just mental health system. However, every time you have to tell a family that you are a mandatory reporter, which is pretty much every time you work with a new family, there's the fear of surveillance. that somebody's going to be paying attention to what it is they're doing and possibly reporting them if they don't meet the expectations. And those expectations are cultural. So that's a problem that we, in our systems have to deal with. Concerns about confidentiality. Somebody can say, yes, it's confidential, but I'm going to report you. Well, okay, how confidential was that? You just said you were going to report me, but you didn't. And then, just some of the wait list times is another one, right? I have a problem or a challenge. I'm struggling with something today, and you're going to give me an appointment 3 weeks from now. Sure, I'll take the appointment, but 3 weeks from now, I'm going to be in a different headspace. And so I might not then need the services or want the services. It won't be quite as, I won't be in quite as much need, perhaps. So how do we do this better, right? We have to show up with a cultural lens. And so culturally competent providers, we are aware of our own cultural groups. And the values and assumptions and bias regarding other cultural groups, right? So those of you guys that I said, if you don't know what your bias are, you've got to learn your own bias first before you can then become culturally competent, right? And we're actually never fully culturally competent. We're just on the journey towards cultural competence, which is called cultural humility. And I'll explain that to you in a little bit. So also, when we're being, when we're trying to be culturally competent practitioners, we strive to understand how some of those factors that I just presented to you affect the ability to, first of all, for me to provide services, as well as for other people to utilize my services. When you're aware of your own personal cultural background, you're more likely to acknowledge and explore how that culture might affect my relationships and other people's relationships. I'm more willing to, when I'm aware of my own kind of bias, my own stuff, I'm able to look at my own beliefs and my own experiences and see how they kind of create what I would consider to be, I'm putting in quotes, but you can't see it, normal or, abnormal behavior. What's normal? Normal to who, right? That's like kind of like we have to go back to that same as well, what is normal? And then also are more likely to understand somebody else's cultural groups and cultural relationships and how that engages, how that influences their engagement in my services or, any supports that we might be looking to receive. So how do we get better at this? Well, the first thing is just take some time to get to know people and learn about different cultures. That's one way. Now you can't, you can't say okay, well, I learned about this one person who's African American, so all African Americans are, right? That's stereotyping. But the more people I get to know, the more I get to understand, different populations, different cultures, different beliefs, different cadence. And it gives me a better understanding of how people are, recognizing that there's, nobody's a monolith and it's not always exactly the same way. Be mindful not to be a know-it-all, right? We don't know everything, so ask questions, be curious. Look at the differences that you see in other people as attributes, as opposed to differences might mean that mine is more comfortable for me, so I think mine is better. But looking at everybody, the way that they interact as something good about them, a strength about them, something that they bring to the table or bring to the relationship. Don't make assumptions. Ask questions, don't make assumptions. And talk to people about their own cultural identities. Like, how do you identify? We do this pretty well in the LGBT area, with gender, but we need to do it across the board. Talk to me about how you identify and just, acknowledge people for what they say. Talk about cultural identity and how it influences behavior with different people. So I might say, in my world, I tend to be very punctual. And some people might say okay, well, that's I'm on white people time, right? But because I just tend to be very punctual. And people from different cultures have different values on time. I do a lot of work in Dade County. I'm sure there's some people from Dade County here on the call. And historically, if I show up for a meeting at 11, the meetings, well, this is pre-COVID, but the meeting would start around 12:30, 1 o'clock, and people will just kind of breeze in when they're ready. That's their culture, you know. And so I had to learn, I had to adjust to recognize that this is the way that this community operates. Recognize that, sometimes culture is an obstacle. If I'm not comfortable talking to my family about some of this stuff, then that's an obstacle to getting support that I need. And then also talk about how cultural groups and identities can serve to be like guideposts in prevention and treatment planning, right? So we're going to center on people's beliefs and incorporate them into the training process. So if somebody's really very faithful, right, that's something that we would consider to be cultural, and we want to use that in our treatment. Is trying to figure out like how pulling in their beliefs about their faith can help them meet their goals. And people struggle with like, oh, well, should I be incorporating religion into the process? It depends on how, important religion is to your client. Because if it's very important to them and you don't address it, you haven't made the connection that you need to make. So let's talk a little bit about cultural knowledge in terms of behavioral health, right? So keeping in mind, different cultures have different beliefs about behavioral health. And again, I'm using quotes, but you can't see. So patterns of treatment, right? Patterns of treatment seeking behavior are specific. So some people will look to engage in treatment. People from other cultures might say that's not even an option. I'm not even interested. Many people from, say, like the Haitian Creole culture are not comfortable with Western medicine and do not want to medicate their children. So recognizing that about that population, having a conversation saying, how do you feel about medication? Not medication is the solution, and understanding where people are coming from. Understanding that their beliefs and their traditions, including their norms around behavioral health. Some cultures believe that people who are experiencing behavioral health or mental health conditions have spirits that they've been exposed to spirits as opposed to something biological in their brain. And so we have to be aware of that to know how do we support those beliefs and try to provide the kind of treatment that we're intended to provide, or not. Recognize that this person's not going to be receptive to that kind of treatment. Understanding that people have beliefs about treatment. It comes oftentimes historical. So people that they know have been involved in treatment and it either did or didn't work out for them. And if it did work out for them, then they're more likely to do it. And if it didn't, well, then you know what happens, right? So recognizing community perceptions. In many faith-based communities, they do not promote getting mental health treatment and believe that you should pray, and that prayer will be the way to resolve any mental health conditions. And, we can't say that that's true or not true. It's what's that person believes, so we have to kind of be aware of that. Recognizing that there are obstacles for certain populations that make it difficult to access treatment, whether that's, funding, whether that's transportation issues, some of those social determinants of health, whether it's their own beliefs. And then also recognize that there's patterns of co-occurring disorders that may be specific to some specific populations. And so some populations, say for example, a Native American population, there's a high preponderance of alcohol and substance use in that population. So then co-occurring might be something that we would be paying attention to, co-occurring mental health substance use conditions. Being aware of all of this right here will help us show up differently, which is what the goal of the training. Now, we want to make sure that we provide that kind of prevention messaging and access to prevention services. Those are community-based interventions that can level the playing field. So sharing information, say like in a school, so that everybody gets it. so people don't feel like they're singled out. And then hopefully children will bring that back to, their families, and the family might be willing to deal with it. Looking at assessments and paying attention to culture in those assessment processes. I'm doing some work right now around working with the first episode teams. And one of the things that's really interesting is that we don't really assess specifically around spirituality for that population, but many of the people that are experiencing that first episode, they might, some of what they might be experiencing might relate to some of their spiritual beliefs. Like if they have the gift of discernment, or they can hear God speak to them, does that mean that they're hearing voices, or is that their cultural belief around that? And so our assessment tools haven't really caught up with maybe some of people's belief systems, and it's something to pay attention to. Recognizing that diagnosis and awareness of that, those diagnostic bias. One of the things that, when we talk about the structural racism, I share an example around how African American or Black men have a higher rate of diagnosis of schizophrenia. And that really relates back to the change in the DSM-2 that happened in the 1960s around, all the protests were happening with the civil rights movement, because the DSM changed their criteria to incorporate aggression and anger, which mirrored the behavior of Black and brown people who were protesting. So like the number of people that were diagnosed with Black men who were diagnosed with schizophrenia went up 95% after the change in the DSM-2. And so that still shows up today, where African Americans are 7%, Black and brown people are 7% more likely to be diagnosed with schizophrenia than white people. And that's something that happened, 50 years ago, 60 years ago. So therapy approaches are different for different people. And again, that comes down to some of those evidence-based practices that were researched on white people for white people. And so are they as effective with other groups? We have to kind of pay attention to that. Peer support, which is such an asset in some communities, in some cultures, it's not as welcomed. And so because if they're not comfortable talking about their experiences, they're not going to then outwardly support others. And so that becomes a challenge too. Looking at alternative healing methods, it's like herbs or meditation, or the use of spiritual leaders as opposed to sitting in an office doing therapy, if you will. And then treatment and engagement and retention policy patterns. So what can we do? How can we show up differently on our journey towards learning more? Well, we can use kind of simple gestures, handshakes, facial expressions, greetings to establish rapport when we know the person that we're working with, what is their preference. And that's really important. Remember, it comes down to that kind of hugging thing. Am I going to give you a hug if you're not comfortable with me, extending, giving you a hug? Well, no. So I need to really understand the people that I'm working with. Recognizing that some people want to get to know you on a much deeper level. So it's not just about talking, it's also about their attitude, their body language, their spirit. Has anybody ever, somebody asked them, would they pray with them before a session? What does that mean? If you say no, because you're not comfortable with that boundary, if you will, well, then are you truly connecting with somebody the way they need to be connected with? And how do you deal with that? That's a much longer conversation, but it's something to pay attention to. We want to make sure that regardless of all of these cultural barriers, that people leave a session with us feeling hopeful. If we open something up that's difficult, we want to try to get them to a space of feeling a sense of hope. We want to build a rapport with people before we start asking them difficult questions, right? And we can do that through various ways, but recognizing how they culturally connect. I'm going to talk about social supports in just a minute. And so one of the things about social supports is that people don't often share their social supports right off the bat. And if you're a professional and you're looking to a professional in the helping field and you're looking to connect with people who are engaged and understand their support systems, you get frustrated by that. But the truth of the matter is they have to get to know you a little bit before they want to tell you all about their relationships and their friendships and everything like that. So these are just some examples. Using culturally responsive interview questions and culturally responsive interview behaviors. So paying attention to things like eye contact and body language, recognizing that some cultures don't make eye contact as much as others. And so how do we, account for that? And how do we continue to connect with the person even if it feels uncomfortable for us? Right? So the first step, most important thing, is that engagement. Remember, most people, the majority of people who drop out of services drop out around the second or third session. So that means that our first and second sessions are really important for engagement. If we start with being an active listener, we'll get invited back to the next session, right? So just by being present and actively listening, and trying to get to know the person and asking slow but engaging questions, and helping understand their belief system about, so how did you feel about coming into therapy today, is a great question. Or how did you feel about getting, me coming out to your home? What did that make you feel like? That's a really important question because that allows people to say like, oh, I was not looking forward to it. So then I know that. So now how do we move forward? Well, tell me why. What did you think was going to happen? That's just being very like authentic, and beginning to build that rapport, which is really important. Don't just jump to solutions before you know people. If we immediately start with like, okay, I'm going to make a referral here, I'm going to do this, I'm going to do that, what we've done is we haven't actively listened to the person. We walked in with our preconceived notions about how we can solve this problem without really getting to know them. And so when we do that, there's a greater likelihood that we're not going to put the right solution in place, so it won't be effective, so people won't want to continue our services. So by stopping, slowing down, and actively listening, we're building that rapport. So let's talk a little bit about how to further engage people. One is, don't use professionalese. Don't use such big words. Like, use everyday language. We in the behavioral health industry, there's so much jargon, so many acronyms. Try to steer clear of that, right? Recognize that everybody is doing the very best that they can, and that everybody has strengths, and find those strengths and talk about those strengths. Find out who are their people, who are their family members, who are their friends, where do they get support from. That's a really important way to kind of like make those connections. Be open-minded and ask, open-ended questions. Don't say like, were you happy to be here? Because you'll get a yes or no, and then what? So we want to be authentic, we want to be warm and engaging, and we want to be flexible. I want to take a moment to talk a little bit about trust and power. And I invite you to put something into the chat. This is a show of hands, but we can't do that, right? And though, how many people recognize that power differential between a person coming in for services and the person providing services? When we say power, that feels a little like icky. Feels like, well, I don't have more power than people, and I don't pretend that I have more power than people. But do you have the power to stop the session? Do you have the power to, as a mandatory reporter, to make a phone call? Do you have the power to collect money? Do you have the power to, tell them that they can no longer receive services? And we do have power in our, as a helping professional, and it's important to recognize that power so that we don't overuse or abuse that power. And even though that might feel uncomfortable for us, to say that we have power, it's important for us to recognize how that influences somebody's ability to come in. If I'm, somebody of color, and, I've been looked down upon or discriminated against by people, of white skin, and then I go in for a therapy session, I am bringing all of that history in with me, right? That bias is going to walk right through the door with me. And so now that person is in a position of power over me. And I don't know, that doesn't feel so good to me. I might not want to engage in that service or that support. So, as the as the helping professional, we have to be aware of that power. And we have to kind of level the playing field as much as possible by being authentic, by being open, by sharing some of our own personal experiences, by being genuine. And not, like remember that video, there was a definite power differential there. She walked in, she had an agenda, she was put, showed the chart, so she had already read all the history. That's a huge power differential. And we don't want that. So how do we address this, right? So we were gonna talk about if they were concerned about coming in, understand a little bit about why, maybe ask them about if they've had trust issues with people in the helping profession in the past and what that was all about. And from the very beginning, address these issues so that you can kind of the elephant in the room, just like call out the elephant in the room, right? It's part of this process. Let's talk about this. This is how I approach this as a, helper. And this is how I want you to approach it too. Are you comfortable with me? What could I do to make you feel more comfortable? And talk about, their current needs. Don't spend so much time in the past, right? Ask them, what maybe has happened in the past, but what is it that you need now? And how can I support you currently in the present day? Talking a little bit about boundaries. And I think boundaries is something that's, as a helping professional, we get a little confused around boundaries because we believe that there are these boundaries set by, say, like our licenses, our standards, by law, if you will. Most of the time, boundaries really come from like ethical practices, and some, like a code of ethics, say like for social work, there's a code of ethics. So that's where those boundaries come from. But many times professionals in school, when they're students in human service, like when I was getting my master's degree, I was taught, like, okay, well, you shouldn't share personal information. I mean, this was a really long time ago, but you shouldn't share personal information. But that was just the teacher's opinion. Like there's no written law or rule around sharing personal information. Now, am I going to share my social security number? No, I would not share that kind of personal information. I wouldn't share that personal information with anybody, But if I have a child who has special needs and the person that I'm working with has a child who has special needs, would I share that information? Sure, if it's helpful to them. And that's really what the boundary really speaks to is it helpful to the client? Because that's the most important thing. We're there for them. So if I'm having a really rough day because my child who has special needs has been acting out and I pop into a therapy session and the person that I'm working with, they have a child who has special needs, is it okay for me to just like vent on them about my child and how, he acted in the morning? No, because that's not beneficial to the client, right? It has to be about them. It's their time. It's not my time. If I need to vent about that, I need to find a friend, a family member, my own therapist. But I shouldn't, use that relationship with the client to share my own personal beliefs. But we get a little, as helping professionals, we get a little confused around, these boundaries and what they are. Most of the time, there's not a boundary that you can't eat or drink with somebody. Now, do I want to always set up my therapy appointment for 6 o'clock because this mom makes the best food? No, that's not right either, because we shouldn't expect the family to feed us all the time. So, we're going to be on this side of right about that, but I think it's important to recognize it's not as formal as I think we think it is, right? So, having said that, not setting boundaries does not lead to good engagement. The people that we're working with need to know why we're here, what we're going to do, some structure around this. So I'm going to be here at this time. Our sessions will be for this period of time. We have this number of sessions as part of this program. But setting those expectations is really important, though. So we want to set expectations, but having really strict boundaries, it also leads to poor engagement. So we have to be flexible. If I said to you, well, we're going to meet from 3 to 4 every Wednesday, and then 3 to 4 doesn't work for you, well then okay, that's not going to work. So let's revisit that. Setting boundaries does set the tone for professional relationships. And though thinking about the power differential, it has to be shared boundaries, right? So I can't say I'm only available from 3 to 4 and that's the way it's going to be. First of all, the family probably wouldn't show up if it's not a convenient time. And secondly, that's not shared. That's me as the professional exercising power. And so sometimes we do have to meet, like, I was just doing some work with somebody who, has a very strict boundary around they always have lunch from 12 to 1. Well, if you're working with families who work, the only time that they sometimes have available is their lunch hour. And so if I'm the therapist and I could take my lunch from 12 to 1 or, like 11 to 12 or from 1 to 2 and meet with a family from 12 to 1, I should do that because otherwise the family is, has to take off of work. So that's something that we have to take into consideration is we have to be flexible when we can be. And so does anybody have any thoughts or questions around boundaries? I feel like that's something that people always kind of like put questions into the chat around this. I don't see any immediately, but I mean, you can take a whole boundaries course. It's just for our purposes here. Our boundaries do impact engagement. And so we do need to pay attention to that. Let's speak a little bit. Somebody said it's a dance to be compassionate and connect with families, but also use appropriate boundaries. 100%. It really is. Like you want to share maybe something about, somebody's very faithful and they ask you a question about your faith and are you comfortable having that conversation? And then where's my boundary? And, it's complicated, but again, the goal is to help people feel comfortable so that they can get their needs met. Let's talk a little bit about cultural humility. So when I spoke before about cultural competence, I said, we're never really completely competent. It just doesn't happen that way. And so we need to figure out like, okay, I'm constantly in a learning process. I've never achieved competence, if you will, because life changes. And so this term cultural humility is what really we should be striving for. So cultural humility involves this ongoing process of self-exploration. I'm continuing to look at myself and say, and learn from others and to recognize that I'm not the expert in everything. And that every time I meet somebody new or somebody different, I get an opportunity to learn. But, to honor their beliefs and their values and their customs and to continue to grow myself. And so rather than saying like, okay, I went to the training, check the box, now I'm culturally competent, it's like every time you meet somebody, you're continuing to grow as a human. And so these principles is just a lifelong commitment to learning. So when you go into a home and you're meeting somebody and they have a different culture than you, you're asking curious questions like, oh my gosh, explain to me that statue in the corner and what is the significance of that? And I see that there's offerings underneath there. Explain that to me, right? People are not like offended that you ask them questions. They appreciate your curiosity and they want to share their culture. It's something that people can really talk about. People are always comfortable talking about their culture and their food and their traditions. So that's something that makes them feel that you're taking an interest in their lives. When we practice the principles of cultural humility, we're actively trying to fix those power imbalances that are created in the behavioral system between the the professional and the client, that dynamic there. And also, we're holding people accountable through mutual respect and partnership that's based on creating this trusting relationship. Right. So you said that you were going to try to be more on time. I can see that you're working on that because I know that that's not part of your culture. And I'm also recognizing that, I'm being a little more flexible with my time too. Right. So we're continuing to grow and to get to know each other and to make this working relationship beneficial. Part of what the families that we're working with say that they wanted was more access to social support. And so I wanted to just share with you some tools that you can use to help families engage more social support, which really speaks to the way that we can, decrease those disparities and create a more equitable space is by working with people in the way that they want to be worked with. I think many professionals feel like it is really not my job as a behavioral professional to help you find friends. It is not my job to get you connected or see that you're connected to your faith-based community. Maybe it's my job to help you communicate better with your family. That part of it. But really, having access to family, faith, and friends improves mental health functioning. So why wouldn't we want to do that? If the goal is to improve mental health functioning, why wouldn't we want to use this tool as part of our toolbox as a helping professional? So the benefits of social support, the research shows that positive association between social relationships and mental and physical health, right? So when you have access to social support systems, you have better mental health, you have better physical health. There's been research around the benefits of social support, and what it does is you live longer when you have social support. You have better self-esteem, you make better choices, healthy choices, and you're more motivated to participate in services and supports. And so we want all of these things in our lives, in our clients' lives. Let's talk about some of the components of social support. So the quality of social relationships, as well as the network, the people, the breadth of people that are part of social support is also about just somebody knowing that somebody cares about you and expresses a concern about you. It's about, social influence, and it's about like the norms, how your society views supportive relationships. Having, like access to people who can model positive relationships and positive behaviors. So when you have a support system that shows you how to do things the right way, you have better outcomes. So let's talk about some potential sources of social support. We already talked about, family, faith, and friends. Also, coworkers, right? If you think about what's happened over COVID, it's been a struggle, right? A lot of people no longer have access to those workplace social supports because people stopped working from home, or people were working from home, so they stopped going into the office. And that really made a lot of people, kind of isolated. But being members in clubs and groups, recreational activities. So what are your hobbies? Helping people identify their hobbies. Then volunteer opportunities, being engaged in educational opportunities, even online communities, though it's not ideal. These are all potential opportunities for social supports. We're going to watch a video that really, this is Andy's a therapist, and he talks about the benefits of social support from the therapeutic relationship. And so we're going to watch this video for a minute. Oh, sorry. Here you go. Watch this video. I like how he normalizes the need for social support, because I don't know if any of you guys, while watching that, you thought like, oh yeah, to take an inventory of my friends, that's something that anybody could do. You know, that's not just something that the people that we're working with could do. That's something that we should do or could do as well, which I think is pretty important with where we're currently at in our world, is to make sure that we have the support that we need so that we can then be there to help other people. So I wanted to just share with you a couple of tools. So one tool that is a great way to use, and we're used to seeing this is in terms of an ecogram, which is looking like at the generationals, but in this respect, we want to use it in terms of social support. So like you would take the client's name and put it in this center circle here, and maybe say you're trying to help them have access to more of a support system. In each of these outer circles, you would think about a different aspect of their life or a different domain of their life, and then ask them, well, okay, so what kind of support do you have in that space? So say, for example, we're talking about somebody who's socially isolated. So in this top circle, I might say, okay, so at home, in the home where you live, if you're feeling alone or lonely, who's the one person you might talk to? And they might, they would say like, oh, I don't know, my mom, or they would say my dog, whatever that looks like, right? So then go to the next circle. So in your neighborhood where you live, if you're feeling alone or isolated, is there one person you might talk to? Like, oh yeah, my one neighbor, sometimes I'll walk down and talk to her for a minute. Put that name there. You say like, okay, the faith community. Are you part of a faith community? If you are, yes. So is there somebody, if you're feeling alone or isolated, is there one person through your faith community that you might reach out to? And you put that person's name here. You go, okay, if it's somebody that goes to school, you say, okay, so at school, if you're feeling alone or isolated, is there one person, somebody in the office or somebody in the lunchroom that you would talk to? Great, put that person's name here. Now you could say if you're part of like a, a gym or a hobby, like a team. If you're, part of a team and you're playing soccer, is there one person on the soccer team you feel comfortable to? How about your extended family? So not the people you live with, but your cousins and aunts and uncles. Is there one person you would reach out to? And you go kind of like circle by circle by circle, thinking about different aspects of their lives. And before you know it, you take somebody who said they had no support, and you can identify 5 or 6 people that they actually can lean on should they need support. So this is a great way to just get people talking about, how they have more access to support than perhaps they're aware of. Another activity that you can do, remember, the goal is we want people to realize that they are connected. So everybody uses their cell phones these days. And this is basically just creating a texting stream with the 5 people who you could count on. And you just approach each one of them individually and say, like, if I needed something, is it okay if I text you? Would you be part of my support team? And then create a support team so that you already have this texting stream already identified. And then you're in the situation where you're trying to go pick your children up from school and you're running late and you're really stressed out about it. You can just pop it into that pre-existing texting stream, and people will be able to respond. And this is something that's proven really useful, is when you already have a line of communications open, it's easier to ask for help. So you want to work with the people that you're supporting, the clients that you're working with, to help them have these systems already in place. Okay, because that will make it easier for them to ask for help. The hardest thing about having social support is asking for help when you need it. So just to finish up. This is a quote from wraparound training, but it's very applicable here as well when we're talking about support. So a family in need of support looks a lot more like a family in need of treatment than a family that has support. So when we're working with people and we're trying to help them build their support systems, because that helps them have better mental health, we need to figure out how do we get them access to that support. So I hope that this information from today was useful to you, and you can think about, what kinds of changes you might want to make to your practice. And if you feel comfortable, you can put something into the chat. But so what's your commitment to creating more equity, if you will? Maybe on a personal level, what will I change based on what I learned in this training? Maybe on a professional level is what will I do differently to better meet the needs of the people that I'm working with? Maybe on a self-care level, since we talked about, creating some support for yourself, is how will I practice this self-care so that I can show up better for the people that I'm working with? And then in terms of communities, what will I do to support the communities and families where I live, work, play, and pray? So these are all things that you can do or should do. So in the chat, people are writing, I advocate for my clients with their voting rights. Okay, so that's one way for sure that you can make a change. Recognizing bias is something else that people feel comfortable saying is that that's something that I can do is go take that Harvard assessment to understand my bias a little bit better. And so here we are at the very end of the training. I just wanted to share with you some references, everything that we've read. And you guys will have access to the PowerPoint so you can see all of these references here. And then my very parting thoughts are to be bold, be brave, and be kind as you practice cultural humility with the people that we work with every day. And I want to say thank you so much for being here and participating. Those of you guys that were putting information into the chat, thank you for saying this was a great presentation and that it will help you continue to learn more about your bias and to do better to provide support to your clients. Thank you. I think Becca has some final parting words.
I do. Unfortunately, everyone, that is all the time we have for today. We've included Dr. Julie's information so that you may contact her with any further information or questions or concerns. And Julie, as always, thank you so much for just an absolutely wonderful presentation. I'm not sure if you can see, but in the chat, you're getting very high praise. Of course, you always do a great presentation for all of us. So a couple of items of business to note before we conclude today's webinar. There is a link to today's evaluation in the chat panel for you. And when I conclude today's webinar, your browser will take you to the evaluation as well. If you want to receive CE credits or statement of credit for this event, you must complete the evaluation. Please note that that evaluation closes April 29th. That's this Friday. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE Broker for Florida licensed healthcare practitioners, you must have provided an accurate Florida Department of Health license prefix number when you registered for this event. After you register or sign in, you will be directed onward to the evaluation. You must use the same email address you used when you registered for today's webinar as what you have listed on your FADAA profile, as this is the only way to connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today. The sender will be Messenger at WebEx. Please note the evaluation will close Friday, April 29th. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. Thank you all for participating in today's webinar. We'd also like to recognize and thank the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's education. Have a great afternoon, everyone. Thank you very much for participating.
Bye. Thank you.